This program is brought to you by Trudell Animal Health.
We'll start off with congenital abnormalities in cats. Congenital choanal atresia is an abnormal bone or soft tissue that's obstructing the caudal nasal passage. This is very different than, say, nasopharyngeal stenosis. We can also have congenital lobar emphysema, which, similar in dogs, is an alveolar hyperinflation due to the bronchial collapse during expiration that's caused by the bronchial cartilage being dysplastic. Brachycephalic airway syndrome can also be found in cats, classically found in our Persians. We can also have pleural bulla, which are blister-like air pockets within the lung parenchyma. Tracheal stenosis tends to be more of an acquired condition, but it can be congenital in our cats. Now let's look at neoplasia found within the feline respiratory system. The nose and the paranasal sinus. The incidence of cancer here is higher in males in both species than in females. The mean age of diagnosis is about 12 years, and greater than 90% of nasal tumors in cats are malignant, the most common being lymphoma, with carcinomas being the runner-up. Tumors of the nose and the paranasal sinus typically are very invasive and metastasize infrequently. Metastasis is more likely in carcinomas and usually occur late in the disease process. Common sites for metastatic spread include the regional lymph nodes, the lung, and the brain. Looking at the larynx and the trachea, squamous cell carcinoma, lymphosarcoma, and adenocarcinoma are the most common types of cancers we see in this area. Feline primary lung tumors usually originate from the terminal bronchioles and alveoli. They occasionally develop as a second coincidental tumor, which may make differentiation between a primary and a metastatic disease difficult. Over 80% of our primary lung tumors are malignant, and adenocarcinoma and alveolar carcinoma are the most common types found in cats. Primary lung sarcomas and adenomas are rare. We can see metastatic spread of primary lung tumors generally to other areas of the lungs, tracheobronchial lymph nodes, bone, and brain. Now looking at our inflammatory diseases, we'll start off with nasopharyngeal polyps. Nasopharyngeal polyps are benign inflammatory lesions that arise from the mucosa of the auditory tube or the middle ear and grow into the nasopharynx or external ear canal. They can produce signs such as stridor, dysphagia, sneezing, nasal discharge, and actually create an upper airway obstruction. Surgery is usually warranted, with traction avulsion being the simplest manner to remove them, but it has a reoccurrence of about 40 to 50%. Now we'll look at feline asthma. This is an inflammatory disease of the lower airway that has no apparent etiology. Feline asthma has a very specific composition, which includes smooth muscle hyperactivity and hypertrophy, mucus production and inflammation, and airway remodeling. Intermittent bronchoconstriction, predominantly due to an eosinophilic lower airway inflammation and an allergic immunopathogenesis, separates feline asthma from chronic bronchitis, which generally entails a neutrophilic inflammation due to a previous insult. There are three key features to feline asthma, which include airway eosinophilic inflammation, hyperresponsiveness, and permanent remodeling. Feline asthma tends to be a type 1 hypersensitivity, where we have dendritic cells that process inhaled allergens. Dendritic cells process inhaled allergens via the regional lymph nodes and stimulate the production of interleukin 4, 5, and 13, most importantly being IL-4. This causes IgE to produce and bind to Fc receptors on mast cells. Subsequently, inhaled allergens cross-link the IgE, causing mast cell degranulation, releasing histamines and leukotrienes, which result in increased vascular permeability, smooth muscle contraction, and mucus production. Eosinophils are recruited, which degranulate and release major basic protein, eosinophilic peroxidase, and cationic proteins, causing tissue damage. Usually the onset of feline asthma is seen in young middle-aged cats. They classically present with acute bronchoconstriction, orthopnea, tachypnea, cyanosis, and wheezing. They also tend to have a very harsh cough, which can be pathognomonic. From a diagnostic perspective, there is no gold standard for feline asthma. The diagnostics usually include chest rads, airway cytology, and the exclusion of other causes, such as cardiac, parasitic bronchitis, or heartworm disease. About 20 to 50% of patients may have peripheral eosinophilia noted on their blood work. They can also have hyperglobulinemia. Looking at chest x-rays, there can be a bronchial, but also a mixed interalveolar consolidation of the right middle lung lobe. Hyperinflation is the classic thing seen on chest rads, and about 25% of these cats may actually have normal appearing lungs on their x-rays. Advanced imaging such as bronchoscopy can also be used as a part of the diagnostic workup. Here, we'll find mucus, nodular irregular airways, hyperemia, and even bronchial stenosis found on bronchoscopic exam. In these patients, we want to make sure that we pre-treat with terbutaline so that we dilate the airways as much as possible. A bronchoalveolar wash can be performed with eosinophils ranging from 16 to 28% of the cytology. Other diagnostic modalities include tidal breathing flow volume loops and measuring the exhaled breath condensate, which can be collected from non-anesthetized cats briefly housed within an acrylic chamber and analyzed for hydrogen peroxide, a marker of oxidative stress. IgE allergen identification has actually been looked at, including intradermal skin testing and via flow cytometry. Treatment for feline asthma patients include oxygen supplementation, bronchodilators, and steroid therapy as an anti-inflammatory. Chest radiographs may not help with monitoring over time due to the permanent remodeling that we see in the lungs. Overall, it has a good long-term prognosis, and most cats can live a good, solid quality of life. Chronic idiopathic rhinosinusitis includes rhinitis or rhinosinusitis that persists longer than 1 month. The overriding clinical sign in both conditions is a cough. One important difference is that asthmatic patients have airflow limitation secondary to bronchoconstriction with inflammation and accumulated mucus debris. Another difference is that asthmatic patients may have an acute onset of dramatic clinical signs such as wheezing. Finally, the cellular infiltrate may be used to differentiate the conditions, though it's not definitive. Specifically, asthmatic cats tend to have, again, a more eosinophilic inflammation, whereas cats with chronic bronchitis have a predominant neutrophilic inflammation. Now we look at pleural effusion. And while it's not necessarily limited to our feline patients, we'll talk about it now. Looking at pleural effusion, our first step is to characterize the fluid. And that's going to look at the protein, the nucleated cell count, and the predominant cell type that's present to help us characterize the type of fluid that's there and essentially know where it's coming from. So the different types of fluid that we can see include a low protein transitive, which is generally attributed to increased hydrostatic pressure, increased vascular permeability, or decreased colloid osmotic pressure. It's going to have more mononuclear macrophages, mesothelial cells, compared to high protein transitives, which are going to have a total solid of about 2.5 to 5 milligrams per deciliter. This type of fluid is due to increased hydrostatic pressure or vascular permeability, increased lymphatic pressure, or impaired lymphatic drainage. Our cytology in this type of fluid will include mesothelial cells, macrophages, lymphocytes, and eosinophils. Our third type of fluid is an exudate. This has a very large total solid greater than 3 milligrams per deciliter and is generally attributed to increased vascular permeability, increased lymphatic drainage, and most commonly will have neutrophils as the predominant cell type. We can also have a Chylous effusion, which is going to have a protein count of 2.6 to 10 grams per deciliter, and is usually due to impaired lymphatic drainage, with a predominant cell type being small lymphocytes and neutrophils. Last up, we can see a hemorrhagic type of effusion, which grossly looks like blood. However, it does not clot. The PCV and total protein measured in this fluid is going to be similar to our peripheral blood. Now let's take another look at chylous effusion, more specifically found in cats with chylothorax. This effusion is going to have a grossly milky appearance, and when we evaluate the fluid, it's going to have a triglyceride count higher compared to that found in serum, a cholesterol count lower than that found in serum, and a cholesterol to triglyceride ratio of less than 0.2 to 1. It can either be a high protein transitate or exudate, and chylomicrons are commonly seen cytologically. The fluid clears with the addition of ether, and the fluid is positive for lipid using SUDAN3 stain. Classically, cats with pleural effusion demonstrate a rapid, shallow breathing pattern with an abdominal component to their effort. They often position themselves with their neck extended and their elbows abducted. During auscultation, it's often possible to appreciate dull lung sounds ventrally, but air movement dorsally. Other clinical findings are dependent on the underlying disease process causing the effusion and may include coughing, weight loss, poor appetite, fever, a heart murmur, and amongst others. Other clinical findings are dependent on the underlying disease process causing the effusion and may include things like coughing, weight loss, poor appetite, fever, or even a heart murmur. Pyothorax is an infection in the pleural space resulting in a septic, exudative pleural effusion. Causes of pyothorax in cats can include trauma, rupture or perforation of the esophagus, trachea or airway, a migrating foreign body, lung parasites, pneumonia with a ruptured abscess, hematogenous spread, and iatrogenic contamination. In one study, oral pharyngeal aspiration secondary to upper airway infection, parasitic migration, and perioperative aspiration were the most commonly identified causes in cats. Unfortunately, many times the etiology of the pyothorax cannot be determined. The most common bacteria cultured from the effusion of cats with pyothorax are Pasteurella, Actinomyces, Bacteroides, Fusobacterium, and Peptostreptococcus. The clinical presentation of these cats will vary depending on the underlying cause, but likely will include some degree of respiratory compromise, such as tachypnea with a shallow effort, dull ventral lung sounds, fever, which can be seen in 28 to 50% of these cats, anorexia, depression, lethargy, and possible signs of septic shock. Diagnosis is ultimately made via cytology and culture of the fluid within the pleural space. The predominant cell type should be the neutrophil, which may or may not demonstrate toxic and/or degenerative changes. Bacteria may not be identified in a small percentage of cases. Therefore, if the fluid is characterized as an inflammatory exudate, aerobic and anaerobic culture should always be submitted. Unless a surgical indication is found during the diagnostic workup, such as an abscessed lung lobe, cats can actually be successfully treated with medical management and thoracostomy tube placement. Broad-spectrum antibiotic coverage is indicated based on the most common bacteria isolates found in prior cases of pylothorax. As such, the coverage should include ampicillin and enrofloxacin or unison. Drainage of infected fluid is key to treatment and is most effectively accomplished with bilateral thoracostomy tubes. These can be the traditional trocar tubes or the low-profile Myla chest tubes. Some people advocate for thoracic lavage with warm sterile fluid with or without additives, such as antimicrobials or anticoagulants, though this has not been evaluated to date and risks iatrogenic contamination. Fluid quantification and analysis can be performed daily to evaluate for the efficacy of your treatment. Ideally, the volume of the fluid and the number of neutrophils should decline, as well as the disappearance of intracellular bacteria. In cats that are not responding favorably to medical management, then surgical treatment is warranted, which would include an exploratory thoracotomy. For cats that receive appropriate aggressive treatment, the survival rate is actually greater than 50%, with a low recurrence rate. Another study demonstrated that cats who survive had a significantly higher white blood cell count compared to those that died. Next up, we'll talk about chylothorax, which is the accumulation of chylous fluid in the pleural space. This is caused by an abnormality of the thoracic duct system where there is a leakage of lymphatic fluid into the pleural cavity. Again, the fluid is comprised of lymph and emulsified fats that form from the gastrointestinal tract, and therefore it's very high in fat and triglycerides. Chyle is drained from the mesenteric lymphatic vessels to the cisterna chyli, and ultimately to the thoracic duct as it runs through the left thorax. The thoracic duct returns the lymph and chyle to the venous system in the craniothorax. The location at which it terminates can vary. Most cases of chylothorax are caused by intact but dilated lymphatics. Causes of the lymphangiectasia include increased lymphatic flow or decreased lymphatic drainage into the venous system, secondary to an obstruction or increased venous pressure. Specifically looking at the causes of chylothorax, these can be attributed to congenital causes, trauma, lymphangiectasia, neoplasia, especially mediastinal, thymomas, or lymphosarcomas, heart disease, such as cardiomyopathies, pericardial disease, heartworm disease, the presence of a thrombus within the vena cava, granulomatous diseases, a lung lobe torsion, peritoneal pericardial diaphragmatic hernias, or idiopathic, which tends to be the most common. Himalayan and Siamese cats may be predisposed to developing chylothorax. Older cats have also been reported to develop chylothorax more frequently than our younger counterparts. Clinical presentation depends on the stage of the disease, specifically how much effusion has built up, and may consist of respiratory distress, a cough, or nonspecific signs of illness, such as lethargy, decreased appetite, or weight loss. Chest radiographs should be obtained, though if a large volume of effusion is present, it may be difficult to identify abnormalities underlying the effusion. In such cases, or in those in significant respiratory distress, a thoracocentesis should be performed prior to restraint for imaging. This can be both therapeutic and diagnostic. Other appropriate diagnostic tests include echocardiography, heartworm antigen antibody testing, abdominal ultrasound, and possibly more advanced imaging, such as a thoracic ultrasound or CT. Ultimately, fluid analysis is required to confirm the presence of chylous effusion. Many parameters have been used to determine if the fluid is chylous in origin, including the appearance and characteristics being opaque, milky, the prominent cell composition being lymphocytes, the triglyceride concentration generally being greater than 100 milligrams per deciliter, and comparing the pleural fluid to serum concentration of triglycerides, in which a higher triglyceride is going to be found, often by several fold, in the effusion. We can also compare the cholesterol to triglyceride ratio, which is going to be less than 0.2 to 1. Whenever an underlying disease process is identified, treatment should consist of addressing that, along with therapeutic thoracocentesis when needed. However, most frequently, an underlying cause is not found. With regards to thoracocentesis, care should be taken not to remove more fluid than necessary in light of the protein, fat, and electrolyte composition of the effusion. Many clinicians will institute medical management despite the lack of evidence to support efficacy. Conservative treatment often consists of a low-fat diet, supplementation with medium-chain triglyceride oil, and rutin. The rationale between a lower fat diet with medium-chain triglyceride supplementation is that the formation of chylomicrons would decrease and thereby reduce lymphatic flow when compared to high-fat diets with more long-chain triglycerides. It was thought that medium-chain triglycerides bypass the thoracic duct completely, but that has since been shown to not be the case. Experimentally, no diet has been successful at reducing the volume of chyle transported in the thoracic duct system. Regardless, it is still believed that the decreased lipid content of the effusion may improve reabsorption of the fluid from the pleural cavity. Rutin is a benzopyrone, and it's a supplement that has been well tolerated and may improve macrophage ability to remove lymph protein and improve chyle reabsorption from the pleural space. Octreotide is a somatostatin analog thought to decrease thoracic duct flow. When given subcutaneously every 8 hours, it was beneficial in 2 of 3 cats in one medical report. If medical therapy is not controlling the volume of pleural effusion and the patient is requiring frequent thoracocentesis, surgery should be recommended. Some actually advocate for earlier surgical intervention to avoid the development of fibrosing pleuritis secondary to the presence of chronic inflammatory fluid. Surgery also allows for the explore of the chest and biopsy of any abnormalities. Thoracic duct ligation is the procedure most consistently performed, but has been met with moderate success. About 50 to 80% of cats will still continue to have some effusion even after surgery. Ancillary techniques reported along with thoracic duct ligation include omentalization, pericardectomy, pleural peritoneal shunting, and the placement of a pleuroport. In 2004, Fossum showed that thoracic duct ligation in combination with pericardectomy led to an 80% positive response rate in cats with presumed idiopathic chylothorax. All right, let's test ourselves and take all that we just covered and apply it to this inflammatory disease case in a cat. All right, so we have Sprinkles, a 4-year-old neutered male domestic shorthair who has been noted to be coughing for the past several days without much improvement. Sprinkles has no prior health concerns and is currently not on any medications. He has no travel history, he's strictly indoors, and he's in a single cat household. So given that presentation, some differentials that should come to mind include feline asthma, various infectious diseases, congestive heart failure, foreign bodies, neoplasia, and heartworm disease. Of course, we will want more information on the cough, including if the cough is wet or dry, if it's productive, if it's triggered by any certain activity, and if it's persistent throughout the day. When we think about coughs in a cat, our top considerations are generally going to be towards feline asthma versus congestive heart failure. My rule of thumb is that coughing cats are inflammatory until proven otherwise. During your initial evaluation, you will note that Sprinkles has mild respiratory effort in addition to being tachypnic. You suspect this cat has lower airway disease. Take a look at these options and tell us what breathing sound would you expect to hear in cats with lower airway disease. All right, did you guys pick wheezing? Because that's correct. Wheezing is often associated in cats with lower airway disease. Remember, the breathing sounds can really help point towards where to investigate next. Remember that wheezing is a high-pitched noise that occurs during expiration, and it's typically due to narrowing, spasms, or obstruction of the smaller airways in the lungs. Stridor is going to be more of that high-pitched noise that occurs with an obstruction around the larynx. Determination of whether stridor occurs during inspiration, expiration, or both helps us to determine the level of obstruction. Stertor is more of a low-pitched, snorty-like noise that occurs from the nasopharyngeal area, and it's the common sound that we see in brachycephalic dogs. All right, one more question regarding breathing and breathing sounds. True or false statement? During inspiration, cats with lower airway disease will demonstrate the most effort. Did you pick false? Because that would be correct. Most effort in lower airway disease is during the expiratory phase of a breath. Expiration is normally a passive process. However, with lower airway disease, there's inflammation and secretion that's produced that can clog the airways and create resistance to the patient needing to breathe against. Hence, the efforted pattern. One of the more prevalent feline inflammatory airway diseases include feline asthma and chronic bronchitis. While the pathophysiology of feline asthma is not completely understood, it is presumed to originate as a type 1 hypersensitivity reaction to aero allergens. Inhaled allergens react with immunoglobulin IgE that is bound to previously sensitized mast cells. This stimulates the degranulation of mast cells and the sudden release of inflammatory mediators such as histamine, serotonin, and other cytokines that result in vascular leakage and smooth muscle spasms that occur during an asthma attack. The allergens that are commonly implicated include dust, cigarette smoke, mildew, mold, parasitic, pollen, cat litter, and household cleaning chemicals. Oftentimes, sneezing and ocular nasal discharge may be seen. There is a wide spectrum of illness severity with some cats seeming relatively normal besides harsh lung sounds, versus some cats that are cyanotic and in complete respiratory distress. So now that you suspect lower airway disease, you decide to take thoracic radiographs as your first diagnostic. Which pulmonary pattern would be most supportive of lower airway disease? So from those choices, a diffuse bronchial pattern would be the correct answer. Classic radiographic findings for feline asthma include diffuse bronchial to a bronchointerstitial pattern. You can also see hyperinflation due to air trapping and collapse of the right middle lung lobe due to mucus plugs. It should be noted that the severity of radiographic pulmonary infiltration has not been found to be associated with the duration of clinical signs. Additional diagnostics would include an airway wash for a cytologic examination, culture, and infectious disease testing, especially for mycoplasma. If cytologically there is an eosinophilia present, then the diagnosis of feline asthma is confirmed. Chronic bronchitis, alternatively, would have a predominance of neutrophils. The most important part of treatment is going to be starting corticosteroids. Besides the anti-inflammatory effects, They will also inhibit cytokine gene expression. They'll also stabilize the cell membranes and decrease the production of inflammatory mediators. Oral or injectable steroids can be given. However, the use of metered dose inhalers and aerosol chambers have quickly become the standard of care in feline medicine. By avoiding systemic effects, aerosolized drugs are delivered right to the lungs and exert local effects. The aerosol chambers are well tolerated and easy to condition patients and train pet owners to for routine use. Given fluticosone's slow absorbency, concurrent oral steroids must be given for the first 10 to 14 days of therapy. Another major component of managing feline asthma is using bronchodilators. So true or false? The use of albuterol for management of feline asthma should be that it is given routinely on a daily basis. So that's actually false. Albuterol should be available, but for use as a rescue drug for the bronchospasms that occur during an acute crisis episode. Albuterol dilates the airways to help in an emergency, but it does not address the underlying inflammation. Chronic conditions like asthma should be managed long-term with a corticosteroid, inhaled preferred, which help keep the airways clear and prevent exacerbations. Owners can administer albuterol at home to help get coughing flare-ups under control, but it should not be used on a daily basis. So let's tie it all together. In summary, the management of feline asthma patients include, in the emergent setting, supplemental oxygen as needed, albuterol, which can be dosed at 1 puff every 30 minutes as needed for the acute control during a crisis, or terbutaline at a 0.01 mg/kg dose, which can be given sub-Q or IM. And in the maintenance phase, the use of a corticosteroid, either oral prednisolone at 1 to 2 mg/kg per day for 10 days following an acute exacerbation, while introducing fluticasone. Because remember, fluticasone takes about 2 weeks until it's at full efficacy. And we want to advise owners to monitor for persistent coughing and/or wheezing, any signs of respiratory distress, squatting with the head and neck extended during coughing episodes, any signs of gagging, open mouth breathing, or if their pets seem labored after exercise. And remember, there are several home modifications that pet owners can do at home to help with managing these patients long-term, such as avoiding exposure to cigarette and/or smoke smells, changing the furnace filters regularly, and controlling for mold, mildew, and/or dust. This and more in our treatment module.